how did you realize the value of 3D imaging, and how did you establish some of those connections and relationships between what you were seeing orthodontically when that patient opens their mouth and you're looking at their teeth or their mouth or their occlusion, and what you're seeing from an otolaryngological standpoint, nasal passageway standpoint, pharyngeal airway standpoint? How did you connect those dots?
Gosh, I think it's been a journey. I think going back to our residency, so much of our focus was on the transverse. We really spent a lot of time looking at the width and really thinking about the importance of ensuring that the bone on the top was wider than the bone on the bottom in order to get the occlusion to stand upright for periodontal health and for occlusal stability. And so really thinking about taking these measurements early on, you can only gain so from a pan and a ceph, you can't gain any information about the width. No. And so like you're talking at Penn as well, we had to have a special request for a CBCT, but if we needed it, we could get that information. So for example, when we needed to do a TAD expander, we could justify that we needed to plan our TAD placement. And so, so we had some exposure, but maybe not as much. And then my first practice was a startup, and I rented space from some periodontists, and all I had was a CBCT.
Okay.
So I was taking CBCTs when I first came out to Seattle as a startup. And once you have it, it's hard not to have it. But like you said, a lot of, especially early on, it was a lot of continuing education I did on my own.
Okay.
Whether it was online courses or working with the radiologists at Beam Readers to learn as much as I could.
Yes.
Because you are, as a doctor, you're responsible for understanding what you're looking at and referring when appropriate.